Hi everyone, I'm going to share with you our research results regarding the treatment of breast cancer metastasis using IAP antagonist. As you know, primary breast cancer can be removed through surgery. The challenging issue is that after surgery, the cancer can spread to other organs, including bone, lung, liver, brain, etc., causing more than 90% of breast cancer deaths. Current therapies have limited effect in treating breast cancer metastasis. There is unmet need to develop new methods to treat metastatic breast cancer. Inhibitor of apoptosis protein, IAP, is a class of E3 ubiquitin ligase, which are commonly overexpressed in cancers. IAP proteins have 8 members, including CIP1, CIP2, XIP, etc., functioning to inhibit apoptosis by degrading caspase, supporting cancer cell survival and growth. Therefore, degradation of IAP proteins is a strategy to treat cancer. Another molecule, second mitochondrial-derived activator of caspase, SMAC, can degrade IAP proteins to activate caspase, resulting in cancer cell apoptosis. You can see in the in vitro system, CIP1 induces the degradation of caspase 3, and addition of SMAC blocks CIP1-induced caspase 3 degradation. Based on the structure of SMAC, scientists have developed many SMAC mimetics, also called IAP antagonists, aiming to treat cancer by degrading IAP proteins. Several clinical trials using IAP antagonists to treat cancer have been published. In general, these IAP antagonists are safe in patients with low toxic profiles. However, none of these IAP antagonists have been approved to treat cancer in clinic because their effect to treat cancer are limited. It is important to identify the factors that limit the effect of IAP antagonists in treating cancer and to develop new approach to improve their effect. We found that the IAP antagonist alone, even given a high dose, didn't kill the cancer cells. Of note, the IAP antagonist effectively caused CIP1, CIP2 degradation. This suggests that degradation of IAP proteins alone is not sufficient to kill the cancer cells. TNF alone doesn't kill the cancer cell either, even given a high dose, because it markedly increases the protein level of CIP1 and CIP2. In contrast, in the presence of low dose of TNF, very low dose of either S164 or BV6 strongly induced apoptosis of the cancer cells, shown by the apoptotic mark Annexin 5. S164 induced the cancer cell apoptosis starting around 1 to 3 nanomolar, and BV6 killed the cancer cell starting around 30 nanomolar in the presence of TNF. The hypothesis is that low level of TNF in the patient could be the reason for the poor outcome of IAP antagonists in treating cancer. To test this hypothesis, MDA231 breast cancer cells were injected into the heart of asthenic mice. After 2 weeks, when cancer cells have established in bone, shown by the BLI signal, the mice were randomly divided into 4 groups, which were treated with vehicle S164 alone, S164 plus TNF, or standard chemotherapy, including 3 drugs, doxorubicin, cytoxan, and Zometa. Before treatment, BLI signal in the bone didn't have difference among the groups. After 2 weeks of treatment, the mice were euthanized to examine the tumor by histology. You can see that half of the bone metastases were eliminated in mice treated with S164 plus TNF. However, neither S164 alone nor standard chemotherapy. 'Therapy' eliminates the established bone metastasis. 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 'Therapy' eli S164 alone or standard chemotherapy can reduce the tumor burden in bone, while S164 plus TNF had a better effect to reduce the tumor burden in bone. Surprisingly, S164 plus TNF completely eliminated lung metastasis. In contrast, S164 alone or standard chemotherapy had less effect to treat lung metastasis. Macrophage is the most common support cell to cancer and the major source of TNF. To determine if macrophage is producing TNF is critical for IAP techniques in treating breast cancer bone metastasis. MDA231 cells were directly injected into the bone marrow cavity of tibia in NSG mice. After 2 weeks, mice were begun to treat with the following 5 groups: vehicle, S164 alone, or SM164 plus either TNF antibody, or clodronate. Clodronate effectively depletes macrophage, as this data show. As the BRI signal show, SM164 alone slightly reduced the cancer signals in bone. SM164 plus TNF significantly reduced the tumor growth as expected. Addition of TNF antibody or clodronate increased the tumor signal in bone compared to SM164 alone, suggesting that blocking TNF signaling or depletion of macrophage attenuates the effect of IAP antagonists in treating cancer. Micro-CT scanning showed that SM164 alone didn't have effect to reduce bone loss. In contrast, SM164 plus TNF markedly reduced the cancer-induced osteolysis. Addition of TNF antibody worsened the osteolysis compared to SM164 alone. Addition of clodronate also decreased the cancer-induced osteolysis, although it increased tumor growth, because clodronate depleted macrophage to inhibit bone resorption. As you know, bacterial component LPS stimulate immune cells to produce TNF, which is required for IAP antagonists to treat cancer. My question is that if LPS derived from microbiota influence the effect of IAP antagonists in treating breast cancer. IAP antagonists SM164, 8406, or BV6 alone didn't kill the cancer cell as expected. In the presence of low dose of LPS, each of these IAP antagonists rapidly caused the apoptosis of the cancer cells, shown by the annexin 5. LPS alone didn't kill the cancer cells because it markedly increased the protein level of CIP1 and CIP2. We then investigate the influence of LPS on the effect of IAP antagonists in treating breast cancer. MDA231 cells were injected to the mammary-fed pet of NSG mice. In the first set of experiment, the treatment began at day 3 of the cancer injection, when the cancer was at early stage development. After 4 weeks of treatment, the tumor size in mice treated with LPS is bigger than those treated with vehicle, suggesting that LPS promotes cancer growth at early stage. LPS plus SM164 had a similar effect with SM164 alone to reduce tumor size. In the second set experiment, the treatment began at day 15 when the cancer were visible. LPS didn't influence the tumor growth. SM164 alone slightly but significantly reduced the tumor size. Addition of LPS to SM164 treatment further reduced tumor size. Similarly, another IAP antagonist, BV6, combined with LPS, significantly reduced tumor size. In summary, LPS promotes the growth of early-stage cancer, but sensitizes the therapeutic response of the advanced cancer to IAP antagonist. Toll-like receptor 4 transduce LPS signaling through MYD88 dependent and independent pathway. You can see that toll-like receptor 4 inhibitor completely block IAP antagonist plus LPS-induced apoptosis, suggesting that LPS-induced cancer cell apoptosis through toll-like receptor 4 when IAP proteins are degraded. MYD88 inhibitor 4210 dose-dependently inhibit MDA231 cell apoptosis induced by LPS plus SMART4, suggesting that LPS induced the cancer cell apoptosis through MYD88 pathway when IAP proteins are degraded. The next question is that what is the mechanism of LPS regulation of IAP proteins that involve in cancer development? You can see that LPS markedly increases protein level of CIP1 and CIP2. Degradation of IAP proteins doesn't affect the level of MYD88. Interestingly, MYD88 inhibitor 4210 decreased LPS-induced CIP1 and CIP2 protein level. Immunoprecipitation showed that MYD88 directly associated with CIP1 and 2. Their association was completely blocked by MYD88 inhibitor 4210 in MDA231 cells. In a word, LPS-induced MYD88 directly associated with and stabilize CIP1 and CIP2, and therefore promote cancer survival and growth. TNF inhibitor markedly reduce a Nectin-5 positive apoptotic cell induced by LPS plus IAP antagonist. Consistent with this, toll-like receptor 4 inhibitor reduced LPS-induced TNF production. This finding suggests that LPS-induced cancer cell apoptosis through TNF when IAP proteins are degraded. ER-positive breast cancer is the most common subtype. SMART4 combined with TNF but not with LPS cause ER-positive MCF7 cell apoptosis. Compared to MDA231 cells, MCF7 cells express low level of CIP1 and CIP2, which were not induced by LPS or TNF. Interestingly, TNF but not LPS directly inhibit MCF7 cell growth. MCF7 cells were injected into the mammary fat pad of a female NSG mouse. The mice were treated with vehicle as LPS, SMART4, or their combination from day 3 and day 15 respectively. After 4 weeks of treatment, the mice were euthanized to measure tumor size. Neither LPS nor SMART4 changed the tumor size, no matter they were given early or late. In contrast, combined treatment of SMART4 plus LPS markedly reduced the tumor size, particularly when they were given early. Chemotherapy is often used after surgery, aiming to kill the remnant cancer to prevent the metastasis and recurrence. A major issue is that the cancer cell can develop multi-drug resistance, resulting in the failure of cancer treatment. We ask that if multi-drug resistance to chemotherapy influence the effect of IAP antagonist in treating cancer. We established a doxorubicin-resistant MDA231 cell to test if SMART4 can kill it. You can see that SMART4, even given a high dose, didn't induce the apoptosis of doxorubicin-resistant cancer cells in the presence of TNF, suggesting that doxorubicin-resistant cell is also resistant to SMART4. We then established S164 resistant MDA231 cell to test if doxorubicin can kill it. As expected, S164 was less effective to kill S164 resistant MDA231 cells. Interestingly, doxorubicin can kill S164 resistant MDA231 cells, similar to their parent cells, suggesting that S164 doesn't induce multi-drug resistance. RNA-seq analysis indicates that the expression of MDR1, MDR2, and MDR3 genes are significantly increased in doxorubicin resistant but not S164 resistant breast cancer cells, confirming that doxorubicin but not S164 induce multi-drug resistance. In summary, TNF increases IAP proteins to block apoptotic signaling. Degradation of IAP proteins alone by IAP antagonist doesn't kill the cancer cells, but allow a low dose of TNF to strongly induce the apoptosis of breast cancer cells. TNF combined with IAP antagonist effectively treat metastatic triple-negative breast cancer. Macrophage-produced TNF is important for IAP antagonist to kill the breast cancer in vivo. LPS-induced MYD88 associated with and stabilized CIP1 and CIP2 to promote the growth of triple-negative breast cancer. LPS stimulates TNF production to sensitize the therapeutic response of triple-negative breast cancer to IAP antagonist. LPS also sensitizes the therapeutic response of ER-positive breast cancer to IAP antagonist because LPS stimulates TNF production to inhibit the growth and cause the apoptosis combined with the IAP antagonist. IAP antagonist combined with TNF doesn't cause multi-drug resistance, but also cannot kill doxorubicin-resistant breast cancer cells. We conclude that antibiotics that kill bacteria to decrease LPS-stimulated TNF production shouldn't be given together with IAP antagonist for breast cancer therapy. Bisphosphonates that attenuate macrophage production of TNF shouldn't be given together with IAP antagonist for breast cancer therapy. IAP antagonist should be given to a patient before and ideally followed by conventional chemotherapy. The research was funded by New York State Department of Health, Department of Defense, and NIH. Thank you so much for your attention.